Hello, and welcome to the Dr. Rebecca Baxt podcast. I'm Dr. Rebecca Baxt, board-certified dermatologist, and I'm here to discuss with you all issues relating to the skin that you're in. In this podcast, we will tackle the topic of the day quickly to get you the take-home points that you need. After listening to an episode, you should be educated about the topic and able to fix the issue yourself or well prepared to ask the right questions at your next dermatology appointment. Let's get started. Today, I'd like to talk about shingles. Shingles is otherwise known as herpes zoster. It is a rash. It is a blistery rash. It tends to increase in incidence as we get older, so it's less common in kids and young adults and more common in seniors, but it can happen at any age. The rash of shingles can happen to anybody who has either had chickenpox or the chickenpox vaccine, which is pretty much almost everybody. Chickenpox is a herpes-type virus called herpes zoster. This is not to be confused with regular herpes that we think of as a sexually transmitted infection or a cold sore on the lip. That is herpes simplex. Today, we are just going to talk about shingles, which is herpes zoster. It's the same virus that causes chickenpox. It's a different virus that causes regular herpes simplex. And shingles appears as a chickenpox-type rash, classically dewdrops on a rose petal, or a blister on a red base of inflamed skin. In chickenpox, the rash can be all over, but in shingles, it just comes out on one nerve root, so it's a one-sided rash. This is called a dermatomal distribution of the rash. It can be on any nerve in the body, so it can happen on the face or the scalp, neck, trunk, arms, legs, hands, feet, groin. I've literally seen it everywhere on the body. We worry about it a bit more when it's a V1 distribution, which means around the eye. So if it's happening on the forehead or around the eye or on the nose, we always send patients to the eye doctor in addition to the regular doctor, so that they can get checked to make sure that there's no eye damage. Shingles, the rash, can be painful, itchy, or completely asymptomatic and painless. It is very variable, but pain is common, which makes sense because it's an inflammation on the nerve root where the chickenpox virus has been hiding out for years. The shingles rash can pop out often in times of stress, or with age as the body's immune system weakens. But sometimes the rash pops out for no good reason at all. And it is important to get the diagnosis correct and treat it properly because it can be contagious to someone who has not had chickenpox or not been vaccinated. So if you have shingles and you have close enough contact with an unvaccinated person or someone who has not had chickenpox, you can transmit chickenpox from the shingles rash. Chickenpox can be deadly in adults and can be dangerous to pregnant women or people who are immunosuppressed. So I always counsel patients, if they have shingles, to stay away from pregnant women unless you know their chickenpox status, and also stay away from anybody on chemotherapy or on immunosuppressive medication, and typically also away from children under 1. Most kids 1 or older have been vaccinated to chickenpox, but if you are not sure, then just stay away. Typically, once the rash is crusted over, it is no longer contagious, and if it's on a part of the body that can be covered with clothing, that is also good and makes it less contagious. But if it's on the face, it's probably best to stay away from others unless you know their chickenpox status so that you do not transmit the infection. In terms of treatment, we treat the rash of shingles with oral antivirals, either valacyclovir or acyclovir or famciclovir. They are all in the same family. They all work. I will typically do valacyclovir because it's easy, it's usually available, it's usually covered, it's generic, and it's 1 gram 3 times a day for 7 days. I tell patients to take it with a big glass of water. It's usually very well tolerated. It does not have many drug interactions, so it's usually easy to do. If the rash is really inflamed or blistery, I will often give a topical steroid, a topical antibiotic, just to try to calm down the rash and prevent bacterial infection. But the rash will go away on its own, even with no treatment. We usually try to treat, especially if it's early on, since we want to try to prevent the dreaded complication of shingles, which is called post-herpetic neuralgia. So that's post-herpes virus. Again, this is confusing because this is herpes zoster. Neuralgia, meaning inflammation of the nerve. So post-herpetic neuralgia means when the herpes zoster virus, which is what causes shingles, disappears, but the pain stays. And that pain on the nerve distribution can be for weeks or months or even rarely years. And it's very uncomfortable. So if someone develops post-herpetic neuralgia, I will often send them to a neurologist for nerve medicine such as gabapentin. There's also an over-the-counter cream called capsaicin, which can sometimes help, Tylenol and Motrin, or a pain specialist. I'd also like to mention the shingles vaccine. It is recommended at this point, as of this recording, for people who are 50 years or older, and I have gotten it myself. It's a 2-shot series, a few months apart. I do recommend this to patients. Even if you've had shingles, it is still recommended to get the shot, although there is a waiting period. You can ask the pharmacist or your primary care doctor. I have actually had many patients encourage me to get the vaccine because they had such a bad time with their shingles, and they want me to know and they want me to encourage other patients to get the vaccine because shingles was so painful for them and they would like to prevent other people from having to go through that. The vaccine does not prevent you from getting shingles, but it makes it heal much more quickly and reduces the risk of the post-herpetic neuralgia, which is the nerve pain. Shingles can occasionally cause scarring, although it's not typical. Usually the marks from the rash will fade, but if someone has scars from their shingles and the scars bother them, then I can discuss scar treatments with them, which are many. And if you're interested in scar treatments, we'll put a link in the show notes to the podcast about scars. So in summary, shingles is the same thing as herpes zoster. It is unrelated to herpes simplex. It's just that the viruses are in the same family of herpes viruses, so the terminology is confusing. Shingles, or herpes zoster, is a recurrence of chickenpox in one dermatome, which is one nerve root, which is a one-sided rash. The treatment is oral antivirals for a week, and sometimes creams can be helpful. The rash is contagious to someone who's never had chickenpox or never been vaccinated to chickenpox. The rash of shingles will transmit chickenpox. The rash will go away on its own, but we treat it to try to reduce the risk of the post-herpetic neuralgia, which is the fancy name for persistent pain on the nerve from the inflammation of this rash. I hope that was helpful. Thank you so much for joining me today on the Dr. Rebecca Baxt podcast. I'm Dr. Rebecca Baxt, board-certified dermatologist. I hope this episode was informative and that you enjoyed listening. If you found this podcast useful, please give us a 5-star rating wherever you get your podcasts. It helps others find us so we can help them too. Just a caveat to remember, this is not medical advice, and please see your dermatologist or doctor for questions pertaining to your specific situation. I look forward to talking with you again in the next episode.